Good morning, everybody. I'd like to thank you again for coming today. We are waiting for Senator Murphy to arrive. He's about running 10 minutes late. If it's okay with you, we're just going to hold the meeting for another 10 minutes. Talk amongst yourselves. Good morning again, everybody. I'd like to begin our meeting today. Call to order. And could we please start with the pledge? And Senator Murphy, would you begin?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you again for coming this morning. We have a pretty loose agenda because I wanted to make sure that everybody was heard. If we should go over 12 o'clock, I think we're going to leave it up to the committee to decide whether we're going to work through lunch. So far, the consensus is let's do that so that we don't have to draw this out, but let's just see how things play out. We'll begin with a review and approve the minutes from August 12th, 2026 meeting. Does anybody have any corrections from the committee?
Have one comment.
Yes.
I think there was a lot missing from Karen Rosenberg's testimony that was important. I mean, she really did talk a lot about the concerns about where we're going, the direction, making sure that we don't harm people while solving the problems that we're trying to solve. And that's really not in the minutes. And I'm a little concerned that that's not there. And I don't know if there's a way to fix that at this point, but to me, it's kind of important.
How would, do I have recommendations on how we might?
Madam Chair, the gentleman can certainly recommend additions. And if we all agree, then they can be added to the minutes.
Do we, sorry, because I'm blanking from a couple weeks ago what was actually said. I just know there was really important stuff that was not included here, so I would have to really think about it. But do we have like enduring content? Was this recorded that I can watch it again and add?
No, although today is being live streamed.
All right.
So what we might ask is for a submission of testimony that might help us.
That would be
Would
awesome.
that be acceptable? Thank you so much. So yeah, we'll make that request.
All right, thank you.
Thank you. Are there any other comments about the minutes? Seeing none, I'd like to do those who raise your hand if you approve the minutes.
I move that we approve the minutes.
Thank you. Do I have a second? Thank you. All those in favor?
Aye.
Opposed?
No.
Thank you. Okay, so today I have extended invitations to a variety of organizations, including, of course, DHHS. And so I'd like to invite the representatives from the Department of Health and Human Services to come up to the microphone, have a seat, and let's begin our discussion. If you could introduce yourselves.
Good morning. My name is Melissa Hardy. I'm the Division Director for Long-Term Supports and Services at the department. And one of the bureaus I oversee is the Bureau of Developmental Services.
Good morning. My name is Doreen Shockley. I'm the manager of the Bureau of Licensing and Certification at the department, of which two of those units are community resident certification and licensing of community residents.
Thank you both. In our correspondence regarding today, I had also sent some questions. I don't know that they'll extend the scope, but I know that we had that back and forth. So please, the microphone is yours.
Yes, so we prepared a quick little just overview of our community resident services that we have in the Bureau, and then we are prepared to respond and answer the questions that you had sent in advance, so we appreciate that. So we would like, I do have extra handouts over on the table as well if anyone in the audience would like to use them. At the end of your packet, there's also an appendix which explains the types of other services that we provide under developmental services, as we might reference them throughout at least this short deck here. Slide number 2, it's just a brief framework of what our funding structure and service expectations are for our 1915C waivers, which is developmental disabilities and the acquired brain disorder waivers. It is 50% federally funded, 50% generally funded by the state. The services must be given in a home and community-based setting. So that means we cannot use any of our funding for institutional settings, whether that's in a nursing facility, a large group home setting, or like in hospitals, things like that. So we're mandated not only by our funding sources, but also our RSA 171A to provide community-based services. In fact, as you probably know, there is no institution in New Hampshire for individuals with developmental or intellectual disabilities. Laconia State School was closed in 1991, which was the institution for people with developmental disabilities, but has since closed and everything transitions to home and community-based care. And just a note on the waiver, Medicaid waiver is basically you're waiving institutional care when you meet that level of care. So medically, you might meet the criteria to be in a facility or in an institution, but you're waiving that right to be in an institution to be in the community. So it allows for community-based care. And that's what the waivers are all about. On slide 3, just a brief overview of the different types of residential services that BDS provides in the waiver. So we have a spectrum here of independent and semi-independent living that could be in their own home, in an apartment. We have individuals with developmental disabilities living in a family home. We also have shared living homes or enhanced family care homes. And then ultimately, we also have staffed residences for those who require a higher level of clinical or oversight of care.
Are we allowed to ask questions as you're
Please.
at any point? I just want to make sure can I ask? I'm sorry. Thank you, Madam Chair. Sorry. I'm not a practice. I just have a question. By family home, do you mean the individual's family or the guardian, or any family of any kind?
Yes, it could be your own family home. If you're living with if you're an adult living with your parents, that could be a family home, grandparent home, that sort of thing.
So if I'm just a miscellaneous family that has a good heart and wants to take care of somebody, would that count as a family home also? That
would be more of like what we call adult foster care, or the shared family living environment, or the enhanced family care home.
All right, thank you.
Yeah. On page 4, we start with just kind of, to your point, just reviewing what types of what these types of residential services mean. So independent, semi-independent apartment. So an individual lives independently in a home or an apartment that they have, but they might access other types of services under the waiver. So they might be using vocational services, volunteer opportunities. They might use community access services, so things like learning about daily living skills. So they're living independently or semi-independently with some help with some other waivered services that we provide. We also have individuals that live in a family home, so live in their home with their family. So every individual's needs vary, and the family support structures can look a bit different. The acuity or the need for family homes is also widely available. So as you referenced, you might have a family member who's able physically, financially, to take care of somebody, a loved one, more than somebody else can who has to work full time. So the level of care varies in a family home depending on the informal supports that a family may have. Also, again, in this type of home, you can access other services on the waiver, like community support services or community integration while living in the family home. You have a question? Oh. On slide 6, we talk about shared family living or enhanced family care home, and these are certified under community residences, and that's Doreen Schock, in accordance with HEM 1001. And like I said, this model is more, in other states, it's called adult foster care. An individual lives with an adult caregiver in their home, and they integrate with their family, that caregiver's family. Again, depending on the level of need and for the individual living with that family, other supports can be compiled on to that day if they want to go out into the community and have a job or learn other like vocational activities. That can be layered on top of being a part of living in a shared family home. And we have approximately 1,200 shared family homes in New Hampshire. On slide 7, it's talking about staffed residences. So these are community residents, again, certified under HEM 1001, where services are provided, again, in the community home that's owned or leased by a provider agency. So they typically support a small number of individuals, commonly 1 to 3 individuals with a developmental disability. And then they have direct support professionals that provide enhanced care to them in that home. It's common for individuals who reside in staff residences to, again, access other services like community support services. I would say the key difference for this model compared to enhanced family care on the previous slide is that most staff residences rely on the support of different staff for each shift of the day, including awake overnight staff. So generally we see staffing on a one-to-one basis, so 1 staff per 1 resident, depending on their needs. So we see the intensity of the direct support professional is greater in this setting.
Yes, go ahead.
I brought this question up with my friends here earlier, but I just spent a week or so ago at the Laconia Housing Authority. And when I'm looking at the picture you have here, that is what they have. And is that the services that they provide, does that fall under this category here?
And you might know more than I do, but the Laconia Housing Authority is really more for people on Choices for Independence programs. So it's more of a congregate setting than we don't provide that service under the waiver because it is a congregate setting.
Thank you.
Yep. And with some exceptions in staff residences, it could be, broadly structured with more staffing in typical homes that we already reviewed. And then, just for numbers wise, there's approximately 226 staff residences in New Hampshire. Of those, approximately 32 focus on providing support for individuals with high clinical or intensive needs. And then prior to 2023, we approximately had 12 staffed residences. So we've seen an increase in the certification of staffed residents as we've been bringing people home from out of state. We were serving anywhere between 60 and 70 individuals out of state, and we have successfully brought about 60 individuals home to New Hampshire where we were serving them out of state. So we've seen an increase in utilization, and we've seen an increase in the number of certified homes or staff residences to meet that need.
Yes, Senator Murphy, go ahead.
Oh, thank you, Madam Chair. We've heard a few numbers. how many overall houses or facilities are licensed or certified total? I saw 1,200 and you just gave us some other numbers.
So for shared family living or enhanced family care, that's your adult foster care homes. There is 1,477 for developmental disabilities and 44 for individuals with an acquired brain disorder. And then for staff residences, for as a whole, we have 496 for people with developmental disabilities and 54 for those with acquired brain disorders.
Follow-up.
Yeah.
For how many of those facilities are they fenced in and people aren't allowed to leave?
I couldn't tell you how many are fenced in. I can say that in every one of these residences, they're allowed to leave. It just might be based on their plan of care that they need somebody with them to leave, or they need two people with them to leave, or they're allowed to leave based on, their care team. They can leave for 2 hours on their own. So it really depends on that individual's need. So I don't know if we have a count of how many homes that actually have a fence.
Follow-up?
Follow-up.
Oh.
Thank you. The last meeting, we heard some, frankly, horror stories about patients who managed to get out of their house, go down the street, and go into other people's houses and cause a lot of shock and dismay for obvious reasons. And they were literally chased down the street and ended up being tased to be returned to their home. So how many people or how many residences operate under a model where that would be likely or possible?
I don't know, Senator, if I have the ability to answer that question with any with any data. I can tell you that the horror stories that you're referring to are minimal. They are not. That's not acceptable, and I'm not suggesting otherwise, but we've mentioned that there are over 1,300 homes in the state of New Hampshire, of which I'm aware of, as the manager of the Bureau of Licensing and Certification, less than a handful of homes that have had situations like that. And I can tell you that the department takes those situations very seriously. We do what we can under law and rule to make sure that the providers are doing what they are supposed to be doing in terms of keeping individuals safe from harm. And since I've mentioned individuals, these are residents that are in their home setting, not patients. They're not considered, they are people that are in their homes. And I'm not suggesting, they're not patients. And that's where we're trying as a state to be very clear that hospitals, have patients, right? Hospitals, but these are individuals that are living in community-based settings. It is very unfortunate that the situations have happened. And often if somebody is following an individual in one of these instances, it's usually staff that is required to have eyes on. And so I don't know. I can go back and look to see if we don't require fencing. People are free to, unless there are circumstances where an individual's needs exceed, and then we would work on the environment itself. But
I just have one follow-up question.
Yes, go ahead.
Thank you, Madam Chair. So, speaking only for myself and not for the members of the committee, of course, I fully support and believe in the good work that your department is doing and these people are doing as far as the shared homes and integration in the community. And so if we're going to consider legislation, I want to make sure that we're being very careful about how we do it and only address the few circumstances things like this may happen. So I think it's important for us to know how many homes we're talking about where the residents cannot come and go, where they are monitored 24/7, and they're not truly integrated into the community because they're not allowed to leave. And I understand you've said that they were allowed to leave, but if they're allowed to leave, but only by having someone with them all the time, and if they leave, there's sort of a community-wide alert, then that's not really the same thing. And so I want to know how many people and how many homes operate under that model specifically.
And we can look into those numbers for you. Don't have them for you today. I just want to say, as part of receiving this funding and doing this program, we are tied to CMS's settings rules. Part of that is allowing people to leave and integrate into the community. There's not any statute or law or rule or program rule that says that people must stay in their home and cannot leave. If they want to leave, if they want to go to Target and they have a direct support professional that's supposed to be with them all the time, that person does go with them. Same with if that person is employed somewhere, they have that direct support professional with them. So, and like I said earlier, some individuals are able to leave for 2 hours on their own to see, how they do in the community. But people do have that right under this legislation, under this funding, to access the community.
And I would just, if I may, add on to that too. Thank you for the question and the conversation. And when we say that a person is not able to leave, it is really comes down to what their clinical needs are. And they might need one-to-one supervision, but they're still allowed to leave. They just need to have the supervision that their clinical needs require.
Representative Nagel.
Thank you, Madam Chair. Getting better at doing this again. You pointed something out that was a caveat that was kind of important to me. You said that, and I'm not going to quote you exactly, but you said that within the basically law, we do what we can do. What I'm wondering about are two things. Number one, is it possible for you to identify gaps in current statute that we can address that can help improve oversight? And secondly, we always pretend that we have no say over CMS, which technically we don't, but we do, in the sense that we can point out this is a problem at federal law that we think needs to be addressed, and change starts in small places. So I wouldn't limit ourselves to state limitations. But is that something you can help us with?
Yes, thank you. I probably would defer to folks behind me in terms of any kind of legislation that might help. I believe that you may or may not already be aware, but in March, the department, along with our colleagues and stakeholders, created or did an emergency rule with HEM 1001 in March of 2026, which gave the Bureau of Licensing and Certification, specifically the unit community residents, to investigate allegations of noncompliance with rules, something that we did not have the authority to do prior to that date. I think that was a critical change. We have also been working and collaborating with stakeholders to improve the HEM 1001. We go in front of JELCAR next month, and our hope is that the rule goes forward. We have committed, the department has committed to the community to engage in regular rulemaking immediately following that JELCAR to improve any part of the rule that needs further strengthening. But I believe a lot has happened this year. And when I mentioned, so a lot of what we do as a department, as a regulatory body, is considered confidential. So while folks are thinking or presuming that nothing is happening behind the scenes, it is in fact happening daily. We increase our monitoring. We're out to places daily. But everybody has a right to due process. So if we take action under legislation, they have a right to appeal that action. And then there are other levels of litigation that can happen if they lose on appeal. So that's what I was talking about in terms of we take the action that we are authorized to take. Does that help clarify? Okay.
I do have a follow-up. So we heard some disturbing events in our last meeting. Were those types of events what inspired this emergency rule change?
Yes.
Thank you.
I have a question regarding individuals who are, have staff who take them out, who are required to be with staff at all times, et cetera. In the case Hollis, I spoke with our fire department chief, and he mentioned that their encounters in public places, there was a language barrier. The staff did not speak English. Can you comment on that? And is there an expectation that those individuals who are required to have staff with them, shouldn't they be speaking the same language?
I would agree that if you are providing, one-on-one supports, you should be able to communicate with the individual that you're supporting. So that would be an expectation of our providers that their direct support professionals can communicate with the individual they're taking care of.
And I'll add on to that as well, that it is the responsibility of the providers to meet the needs of their residents where their residents are. So that would include being able to communicate effectively.
Is that a requirement?
Yes. To be able to meet the needs of every resident.
As long as language is part of that, is that part of the rules and requirements?
The rules and requirements don't say you need to speak the same language, but you need to be able to communicate effectively to meet the needs of your residents. So I would, if we were aware of situations where that wasn't happening, we would address that with the providers. Does that answer your question? I mean, does the rule say you must speak the same language? No, the rule doesn't say that. But one would be required to meet the needs of the residents and be able to communicate. So yes. But it doesn't say that.
I guess that's one area where I would like to, I'm curious if it should be explicitly communicated, because I would imagine some of the individuals, the lack of communication would be frustrating and could exacerbate a situation. So I would think that would be a requirement.
Yeah, and I think we can take that back to look at what our rules are as it regards to like person-centered planning. So if I'm a service coordinator, a provider, a guardian of somebody, that would be part of my plan, that the person taking care of me can communicate with me. So although it might not be in a law somewhere, that's part of person-centered planning. I can look to see the language as to what that, if it speaks specifically to that, I don't know. But that would be our expectation, is that when you're planning care for somebody, that communication is one area that you're planning for. And I agree, if you can't understand each other and you have a language or even a communication barrier, that is a circumstance where something may happen.
Thank you. Representative Drago.
Thank you, Madam Chair. Just to follow up on what you guys had just said, you aren't aware of the situation that my colleague brought up. You guys didn't know that was happening. You made a comment that if we had known about it, so I just want to see if you guys were ever notified, if you knew that there was a language barrier in some of these houses, or?
We were not aware of that specific case that was mentioned. At least I wasn't, and Doreen was not. We were aware of the concerns about that provider, and we're doing oversight of that provider, but I don't believe that specific instance came up as a problem.
Okay,
Follow up.
it's actually a different topic. I just want to go back to the fences conversation we had. A lot of things that I have heard from constituents in my town and other towns is what they call character of the neighborhood. And they seem to feel like it's almost being ruined by these gated houses that are going up. You said you don't require fencing. Do you have the ability to tell these providers that you need to maintain the charm of the neighborhood? You can't make it look like Fort Knox. And do you have that ability, or do you need different rules to do that?
I don't believe the department has the ability to do that. I would probably deflect that to the Department of Justice as far as, I don't have any right to tell my neighbor what type of fence they can put up or, what type of lawn ornaments they have on their front lawn. It would be we see that as the same way. They're your neighbors. There are certain things that I wish my neighbors did and did not do, but I don't have any control either through an RSA or through the town, if they're not violating any town ordinances and putting up a fence or, other structures on the property.
Comment / follow-up.
Yes.
Our towns keep being told that they don't have to follow zoning or ordinances. So it's tough to say that they don't follow ordinances because it seems like they're allowed to do whatever they want on these properties. So there should be some sort of guidance, in my opinion, on what can and can't be done to not make the neighbors have to look at. I wouldn't call it an eyesore, but it went from a nice neighborhood to it's not the same as what it was before these homes moved in, if that makes sense. So, but to say that they have to follow ordinances, we were told they don't have to follow anything. The town has no say in that.
I would say as far as, like and again, way out of my league, but as far as, a fence, I would assume they would have to follow it. I know my town has I think it's a 6 or 7 foot limit. But again, I would defer that question to probably the Department of Justice on, why or how these community residences do or do not follow local zoning or ordinances. So again, just going back to the slide, and I think this is probably the subset of individual homes that we're talking about, that we've been talking about with these follow-up questions on slide 8, are called intensive treatment services. So they're a subset of supports that are provided in a staffed residence. There's certainly considerations with individuals who require intensive treatment services. So they either need more behavioral interventions, medical interventions. They might have a history with, problematic sexual behaviors. They might have a history of, being harmed to themselves or others. So this is really our highest level of needs and services that we provide in a staffed residence. So they're addressing, those specific needs of individuals with developmental disabilities that have those types of behaviors. The primary objective is to safeguard the community well-being as well as ensuring that the individual is safe and has the support of the direct support professional and the provider. It's the level of supervision or the level of staffing is tailored based on different risk assessments and care planning for the individual living in the home. And again, there could be one person living in the home, 2 or 3 people living in the home. So every one of those persons have their own individual plan of care, which outlines, the level of staffing and supervision and interventions that they may require.
Yeah.
Go
I'm
ahead.
sorry, Representative Drago.
Thank you, Madam Chair. Who decides how many people live in each house?
Well, the homes are certified, so the certification unit, I don't want to speak for Doreen, but certifies the number of people that are able to live in a home. So certified residence is anywhere from 1 to 3 individuals.
Follow up.
And how is that? Is it based off bedrooms? What's the criteria to decide if it's 1 person or 3?
I'm not sure I'm understanding your question. So it would be similarly to somebody buying a house. They would work. If there's 3 bedrooms, then they could have 3 people. On page 9, it describes the certification is a community base which has 3 or fewer individuals, and then if they exceed 4, if they go 4 or more, then they're also licensed. So they have a certification to be a community residence, and then they're also licensed to provide services and residential care to more than 4.
Last question, promise.
I'll let-
Okay, so it's based off bedrooms, which is kind of what I was asking. Is probably the main thing. I guess the issues I've also heard is during shift changes, there's a lot of extra vehicles. Some driveways aren't big enough. There's a lot of parking in the roads. Is any of that taken into consideration when the certification process goes through on, you may have 3 bedrooms, but if your driveway is the size of this desk and only 1 car can fit, well, you might not be able to have 3 people with multiple nurses or multiple staff. Is that taken into
That's not
consideration?
something that we would be looking at in
Okay.
certification. I will say that if we are contacted by neighbors or folks that have concerns about that, we do work with the provider and encourage them to find other ways, places to park, to make sure that they're not disrupting. It is important for us to remember that the providers need to be good neighbors. So it is their responsibility to make sure that if there are concerns like that, that they make every effort to, stagger shift changes or whatever that might look like to make sure that they're not impeding on others.
Thank you. Okay.
And just a few other bullets for the intensive treatment service homes. There are environmental considerations and modifications. So I think one of those that was already brought up, would be a fence if somebody is, at risk or at danger of eloping. But also things like delayed egresses, alarms on doors, internet filtering. So kind of putting like a parental control over what can be seen through YouTube or on the internet. Self-harm prevention materials. In some cases, if somebody has a history of self-harm, making sure that their room and on their self, they don't have anything that can hurt themselves. So able to do that sort of wellness check on those individuals. One thing I also want to emphasize is that the individual service plan really is what drives the level of care provided to an individual. And things like risk assessments, the interdisciplinary evaluations, neuropsychological evaluations are all taken into consideration with the care team and also the individual receiving services to come up with that plan of care that keeps them safe, but also gives them that level of independence that can keep them safe. So it's like I said, our most intensive service that we provide. I think there's a misconception that everyone in one of these homes is either from the prison system or from SPU, and that's not necessarily true. But we do have individuals that have a history of problematic sexual behavior, fire setting, those sort of things that do have a primary diagnosis of a developmental disability. Roughly, we have about 7,000 individuals accessing home and community-based services, and approximately 90 individuals access this level of care, this intensive treatment services care. And so when Doreen talks about, we serve, and we can give you more specific numbers, we serve X amount of people, and there have been instances where there has been some cases that I'm sure you've heard of, and I know I've talked to some of you about individual cases, but this has been a successful model since the closure of the institution. However, there are certainly cases where it doesn't go to plan, and we either have to step in with the provider, work with the town to make sure that not only the individual is safe, but to make sure that that the town is being heard. And we truly encourage and drive our providers to make those relationships in the towns so that they know who the fire chief is, they know who EMS is, they know the leader of government in that town, so they can make those relationships and be good neighbors.
I have a question related to that. So there's encouragement, but no requirement.
So there have been circumstances where the department, the Bureau of Licensing and Certification Community Residence Unit will issue what is known as a directed plan of correction. So if we encourage a provider to engage with the community, to do education, and they don't, we'll issue a directed plan of correction that says you must do this, and it must be no later than, and we generally give 45 to 60 days, depending on the severity of that relationship. We have been known to give 15 days or less. So we can, in fact, require that if it's necessary.
Have you done that recently?
Recently being, I've done that in the last couple of years, yes, on more than one occasion.
Representative Nagel.
Thank you, Madam Chair. How do you find out if there are problems?
Neighbors, you, staff, people walking by at a Target. We get, people, understanding that as the Bureau of Licensing and Certification, we oversee from birth, childcare, daycares, nursing homes, hospitals. We receive over 400 allegations a month. So they come from everywhere. And I will say, well, I won't say that.
Follow up.
Is there an easily identifiable process for me if I have a concern to contact you?
So there will be. What I thought was transparent and easily accessible. We've recently learned that that's not the case for everybody. Having received that many a month, and that's on our website. But from what I'm hearing recently, we need to improve that process so that those that don't have access to internet or the DHHS website is not, it's so much improved, but it's not user-friendly for everybody. So I am working with others on making sure that that process is known. In some facilities that are licensed, we require that they post the complaint process on a wall. In community-based settings, that's not always ideal because it is a community-based setting and you don't want it to have the feel of an institution or a facility. So it's kind of, a balance there. But I think we've gained a lot of momentum in the last 6 months, and I would expect that our rules will articulate that process far better in the future.
Follow up.
This is actually a new question that just came up with what you just said, which is, do you have a geographical map of where all these facilities are, and is our rural environment, how many homes are in rural environments, that kind of thing?
I do not.
I think I would have to defer that question. Some of these community residences, due to privacy laws, we don't make a map public as far as where the certified homes are. If they are your neighbor, they could be, living next to you in a shared family home and you don't know. I think we certainly have a list of homes that are certified and licensed, but what can be shared to the public, I would have to defer again to the DOJ as far as privacy rules and rights.
Thank you for answering. I did not understand the question entirely, so that is absolutely correct. Thank you, Melissa.
I think the next slide is for you, Doreen. I know we already looked at it a little bit as far as the Bureau of Licensing and Certification.
So the slide does describe what I just mentioned in terms of when certification versus licensing is required, and that the Bureau and the unit are responsible for regulating and overseeing the compliance with rules and laws.
I have a question about certification. How often does a provider or whomever owns the home or runs that facility come for recertification on that particular residence?
Annually.
And as part of that, I had been reading into that, the certification to better understand what is required. And part of that is talked about an agency would not, if it has been, if it is under a fraud investigation or has been found to be fraudulent, it cannot be considered. And yet we have a case with Community Options where there was a case against them. And I think it was in 2025 that it was found against them. Can you talk a little bit about that situation?
I cannot. That would be for our attorneys to discuss. And I don't think there are any here today.
Okay, thank you.
And just moving to some of the questions that you provided us prior to today, I think we hit on some of them, but just wanted to go through and make sure that we answered your questions. One of them, what are the respective roles and responsibilities of the different parties that are in our service delivery system? So, we talked a lot about licensing and certification. The Bureau of Developmental Services, where in our department or in our bureau, we authorize the funding for all of our services under the waiver. We work with service coordinators, with area agencies, with service providers to become enrolled in Medicaid so they can be a service provider in our delivery system. Area agencies are a key partner in our success in the community. So they are basically our front door to developmental services. So they provide the intake and eligibility process. They provide family support and are often a part of the conversation when it relates to what level of service somebody needs, along with service coordinators. Also, our provider agencies are ultimately the agencies that are responsible for the service provision and the day-to-day operations of their programs. So that would include the health and welfare of the individuals that they support. So if there is a complaint that comes in, whether it's from an email or a phone call, we hold the provider accountable to ensuring that individuals' health and welfare are safe. And we can do that in a few different areas. We can use Doreen's department as far as a licensing and certification. We also have the Office of Client and Legal Services that investigate concerns as it relates to individual rights violations and service provision issues that may be reported by the individual themselves, their families, any staff working with them, and then the providers themselves, area agencies. And then ultimately we have adult protection services. So if there's any allegations of abuse, neglect, or exploitation, we would have adult protection screen the case and follow their rules to either open a case or investigate a case. So those are kind of our three levels of safeguard of regulation oversight that we have in our developmental system at this time. We talked a little bit about, any questions about that? Okay. We did talk about the occupancy threshold. So for certification, it's 1 to 3 individuals. And any residence that's 4 or 4+ individuals would need certification and licensure. I don't know, Doreen, if you want to talk a little bit about the next question as it relates to inspection and ongoing monitoring.
So, without the mic, I'll do that. As I mentioned we have annual inspections for recertification. We also, when we open up a file or an investigation based on an allegation, we will also go out and investigate the circumstances surrounding the allegation. If the situation rises to the level of monitoring, we will monitor. We have been known to drop into homes on a Sunday morning at 6 a.m., on a Friday night at 11 p.m. So we will do that if the circumstances warrant that. We also then take other action as necessary if it rises to that level, as I described earlier.
Representative Nagel?
So in all the roles that I serve here, one of the recurring themes are staff shortages. You said you had 400 allegations per month.
That's across the Bureau.
Do you have enough staff to deal with that?
So that's across the Bureau. That's 4 different units. I am fortunate enough that the teams help each other out too. So, I mean, I wish I could have more staff. But I don't know how to answer that question. I think, and I'm sorry, it's an easy question. I would like to fill the vacant positions I have. You bet.
You win.
Is this being recorded? Great. Lovely.
The next question that was posed is how are building fire safety, occupancy, and accessibility requirements reviewed and enforced before and after a residence is open? I didn't know if we wanted to have further discussion about that.
Yes, I have a question. I was looking at the information that was sent to us after hearing from the Raymond Town Administrator, and he had, of course, he had contacted the Attorney General. Well, he contacted DHHS, which referred him to the Attorney General's office, and a letter was emailed, basically saying that community residence is a I forget the right term. It's agent of the state, so that it precluded them from having to present to a planning board on the use of that particular residence. However, there is another RSA, 672, I think, that talks about the idea that there is essentially a courtesy, the ability for a town to request that an agency come before them in a non-binding result to discuss particular aspects of that dwelling, any concerns that the town may have about the siting of the dwelling. The town essentially gets to present their concerns about that home because this is all triggered by a change in use. So we go from a residential home to essentially a staffed home. So with regards to the fire safety issues, this particular aspect of that non-binding, is that part of a correspondence that should, in your opinion, be going to the town when a home changes from a residential home to a staffed home, regardless of whether it's 4 or above residents or 1 to 3 residents? It is a change of use. Is that something that DHHS would recommend be included in some kind of a packet to the agencies or to the community residence providers, that they then notify automatically a town that this is an option to you? We can have that non-binding discussion with town officials.
I think wholly I would probably defer again to the attorneys in the Department of Justice on, the line where, we're prescribing who can live where versus, discrimination laws and things like that. So I don't want to speak to that piece of it. I would say that having a certified home with 1 to 3 people living in it doesn't necessarily change the use of the home. People have family members that live in their homes. They have 4, 5, 6 people, and nobody has to notify that, that there's additional people living in their home. So I would say that at this point, we would say that these are individuals living in their homes in a community. So I'm not sure what that process would be or look like to, have a town discussion on the use of that property if the property is being used as somebody's home. It's not considered an it's not considered an institution level of care.
I also wanted to add on to that, and I think this actually addresses one of the questions you had earlier, Representative, is that in order for us to certify a home, the agency must first obtain an inspection by the fire department to ensure that the physical environment is safe and does not exceed the maximum occupancy allowance. I think that goes to your question as well.
So to my understanding, in town of Hollis, there was no such information extended to the fire chief. I don't believe. Before I say that, let me just double check. Yeah,
And
thank you.
And we can follow up on that too, as far as, prior to being certified or given a certification. Our team or Doreen's team would have to have those conversations with the local fire department.
Thank you so much.
Thank you, Madam Chair. You said something earlier that stuck with me, and I just want to make sure I understand it correctly. The rules say that all residents must be able to come and go as they please. Is that accurate or not?
Residents have the right to come and go as they please based on their plan of care. So if they need somebody with them 24/7, it's been decided with the care team that they need continual supervision and they want to go to Walmart, they can go to Walmart with that person with them.
Follow up. So there's either the doors are locked so they can't leave whenever they want without talking to the right people, or there's a fence around with a gate that's locked and they can't leave the premises without talking to the right people. Is that accurate?
I would say if somebody is authorized to have somebody with them 24/7, that person is supervising them and interacting with them 24/7. So the cases of somebody leaving the home without notice or without somebody being with them should be rare if they're in that type of staffed residence.
And since we're dealing with comments, if I made one comment and phrase it as a question, if I can. It seems to me that there's a very important difference between a true residence that is accommodating the needs of people who need help, but are truly integrated into a community. And what is truly, to me, it's more of a facility. If the doors are locked and they're secured and they can't just walk up, turn a handle and leave. I don't see that as a residence. If they can't walk up and turn the handle and walk out, if the house catches on fire.
Right. I just want to clarify that not all of these homes are under lock and key 24/7.
Oh, I understand.
Yeah, and they're not.
I believe that's a tiny minority we're talking about, which is why I asked for the numbers earlier.
Right, exactly. So, other interventions they have, some homes have like door alarms or window alarms. So if somebody were to leave the residence or open a window, it alert staff. So I wouldn't say that, they're under lock and key and cannot get out. Some of the reasons surrounding like putting a fence in is to allow somebody to be outside within the confines of their own, property without, the ability to flee from their direct support professional. So it really is an individual case plan for if somebody requires that level of care or supervision.
Thank you.
If I may, I'm not aware of, doesn't mean they don't exist, where buildings are locked. The goal would be for like, if I see you get up and you're walking towards the door, I am your direct care super person, and I'm going to get up and walk towards the door with you, and I'm going to observe what your next actions are to make sure that you're safe in the environment. If you open the door, I mean, people are, and I think that's what we mean by people are free to go. Do they have supervision? Yes, their clinical needs require that. But it's not like, now, have there been times reported where staff isn't doing what they're supposed to be doing? Yes, that does happen.
Even if you have to go to the restroom and you're gone for 6 minutes, what stops me, the resident, from reaching for the door handle?
So in those particular cases, you are, as the provider agents, as the provider, you are responsible for having enough staff to meet the needs of all of your residents. So if we're 1-to-1 and we're 1-to-2, then I need to make sure that I let you know that I'm going to the restroom and I'll be back. I mean, it's like, that's the way it's supposed to operate. Like a person that needs 1-to-1 24 supervision is meant to have just that for their own safety.
Thank you, Madam Chair. Thank you.
Representative Nagel.
Thank you, Madam Chair. Thanks for taking my question. I really struggle with this concept of acquired brain injury, mostly because a lot of what we're talking about is very common in the Alzheimer's community, which in a real sense is an acquired brain something, if you want to call it an injury or something else, but it's the same thing. And a lot of what you just described are measures that we use in older folks to prevent wandering and keep them safe and try to keep them in their homes. So it's kind of like we already have this model that kind of works. Most of the time it does. But I don't see that there's a huge difference there. Am I wrong?
I think I would say the difference is most of that care, provided to individuals with dementia or Alzheimer's are in like a residential setting, right? So a larger group of people living together, a congregate setting, where, within our program, we're not permitted to use our dollars for a congregate setting like that. I would say that's the major difference.
Yeah, I get that totally, but I've been doing this for a long time, and we really try to keep people in their own homes for as long
Absolutely.
as they can. And a lot of these measures like door alarms and whatever, we use all that stuff to try
Yes.
to keep people safe. So I do have a follow-up if I could. I'm just curious because, the concept of the response of the community, the neighborhood to the presence of these places within their community has been brought up multiple times last 2 sessions. Are there any surveys out there, studies, whatever? Because we know we do this with methadone maintenance programs and things like that, about how the communities adapt to this kind of thing, satisfaction concerns, things like that. Because I know a lot of times when these facilities start, everybody's reluctant, and then the minute they're there, they find out, it wasn't so bad after all, and then, it actually becomes a good thing for many communities. And I'm just curious if that survey data exists and if you're aware of that.
There's no survey data that I'm aware of as it relates to that. I do think, we're bounded by some privacy laws as well. So like I said, you could have somebody who is, in a shared living environment living right next to you and you don't know, right? Because there's been no concerns, and they're living in a private residence. So I think that contrasting with the methadone clinic that you're talking about, that's an open business that, people are aware of. So I think it's a bit different, but I don't think we've talked about surveying, communities, not saying it's off the table, just we have not done that.
One more fault. Has anybody anywhere done that that you're aware of?
Not that I'm aware of.
we were looking at the questions that,
Yeah, I think we talked about, the limitations that exist and privacy requirements. I think we really, again, have to refer or defer to the Department of Justice and our attorneys on that, as BDS doesn't have any requirements as it relates for that, other than, that we consider them part of our communities, so part of our neighborhoods. The process for receiving, investigating, and resolving complaints, we went through what Doreen's bureau does. We also have our Office of Client and Legal Services and Adult Protection. And I know, I don't want to speak for Doreen, but on a daily basis, we get inquiries, whether they're congressional, whether they're, from a representative, from a neighbor, from a hospital, about concerns, whether it's property maintenance or they heard somebody yelling overnight or somebody was walking down the street alone. We manage and take those calls from anybody and follow up with those providers. So, there are those three official ways to do that, but I know that we certainly take, concerns from anyone that calls into the department and follow up on them. And then which entity is responsible for correcting violations or property maintenance problems? I think it depends on the property in question, but ultimately the provider agency is responsible for ensuring the physical environment is appropriate for the individuals living in the home. And Doreen's team can certainly step in if there are things that should be or should not be in the home, to inspect that and make recommendations or have a directed plan of correction to fix, or improve that environment of the home. Do we maintain a number or location ownership capacity? I think Representative Nagel, that's what you asked about. Doreen's office has software, ancient software, I should say, that, tracks, where homes currently are, what homes are currently certified. Again, not open necessarily to the public, but we do have that tracking mechanism.
Representative Nagel.
I really feel obligated to make a point because you referred to the word ancient. Having now adapting to yet another electronic medical record, there is total value in ancient software.
Noted. And then how does the department respond when a provider stops operating a residence or a contract change or a property is sold? So that provider agency needs to comply with our rules. So HEM 504, which is our provider and provider agency rule, and 1001, which is the rule that Doreen's team enforces for community residences. Any contract changes would have to be negotiated with us at the state in whatever contract that we have with a provider. If an agency ceases their operations, there are rules in which timeframes must be complied with, notices must be complied with. If we decide that a provider should no longer be providing services, they also have their own due process to appeal to our administrative appeals unit and further, if they don't agree with us saying that they should not be a provider of a certain service in our state. We talked about how individuals are selected and placed in community residences and what factors, location, size of the home, and types of homes needed. We also have rules in BDS where an HEM 503 talks about the eligibility and process of providing services. So those are outlined in that rule in 503. And, within those different types of living situations that we've already discussed. And then I think your last question was about statutory, regulatory, or administrative changes the department believes would help improve oversight. I was going to say technology, but I might take that back based on your response to technology. But I do think, in order for our bureaus and divisions to speak to each other, having a platform where, we're not reliant on emailing each other. Doreen and I are in contact every day. If there's a problem, I know from Doreen, or if there's a problem, Doreen knows from me. There's no one technology system that marries all of that together. So I do think, technology of some sort, probably not yours, but would certainly be helpful in the communication between our department, Doreen's department, our legal department, to know, what's going on in real time without, making a phone call or hearing it from the paper, or, having to write an email to inquire, what's going on in a certain location.
And I'd like to add to, it kind of goes to what your question was earlier, and complaint process. The department currently does not have the staff or the resources to implement this, but if you were going to ask me what I wish for, would be legislation or whatever that looks like with money attached that would give the department staff and a platform so that folks can, one number, one contact, call and make an allegation or a complaint, and the department then is responsible for making sure that the units in the bureau that need to have that information, so that we don't ask constituents, loved ones, neighbors, well, you've got the wrong place. You need to contact XYZ. That would be my dream. Again, it would have to have money attached.
Can you put that in writing? No? Oh,
Well, yeah, I guess I could. Yes, I think I can do that.
we do have the recording anyway, so, yeah.
It would be helpful to have a list submitted, and we can put it in for the record, for sure. I do have a question, kind of going back up to the fire department issue. Are medical records for the individuals in the homes? And the reason I raise this question is we had a situation where a resident was outside of the home with their caregiver. Same situation where that caregiver did not speak the English, in this case because it was an English-speaking resident. And they were unable to share with our EMS and fire department any medical information, which really can be, quite frankly, dangerous for that individual if they're in a situation. And so how is that handled, and do you think that there can be improvement in that area?
I will say each individual residing in a community residence should have their individual service plan in the home, which would describe kind of their primary diagnoses. They have a medication log if they're receiving medications. All of that is on the premise of the community residence, in a safe spot. Usually one of the rooms is converted into an office space for the staff. So that is on the premise of the community residence.
Follow up. So that being the case, is that available to our emergency services? Should they need to, they be called to the residence? And then if that resident is taken, out for the day, how is that information expected to be relayed should they have an incident while they are outside of the home in the public area? Help me bring this all together.
Yeah, I think part of that is on the provider. So if I'm a provider and I have my staff taking care of Doreen, part of my job as a provider is to educate the staff on Doreen's needs. So if she has, if she's allergic to shellfish, if she's, kind of those, if she requires, eyes on 24/7, some of that is part of provider policies and procedures. I would say that if EMS was called and there was some sort of medical emergency, I don't see why they would not share that information. There's no limit to sharing that medical information if somebody is in a medical emergency.
I would agree with all of that. It's also, when we're on site, we're looking at files. And it is a requirement for all staff to be trained before taking care of an individual on what their individual needs are. So I don't know the details of what you're describing, but it sounds like if that had been called in, we would have opened an investigation.
Representative Nagel.
Thank you, Madam Chair. I have to preface what I'm going to ask you by making a comment. I began my career, this addresses what your wish list is. But I began my career in stroke rehab, developing functional outcome measures that are used all over the world now. And my personal belief is if you open up a stroke unit, I would never use them in a million years because I saw the problems that they create. With that said, I also I'm on a board that oversees 8 nursing homes through Catholic Charities. I know we've already pointed out the difference between that institutional setting and the community setting. However, quarterly, we have to look at outcome measures, and those are reported. So, and the entire state knows what our outcome measures are, and we can see things in real time. And we do this quarterly. And if your numbers are bad, that's not good, because that's how you sell a nursing home to an individual. And I'm just curious, is that the kind of model that you're thinking about having, that we do regular assessments of these places, that these numbers are seen on a regular basis?
I would say in the nursing facility field, which is heavily regulated, as you know, not only from the state but from the feds, they require looking at certain measures as it relates to the quality of care, staffing, all of those different factors that are prescribed from the federal government and from the state. For our measures, we have measures in our 1915C waiver that we have to report out on annually that are not, I will say, is not as robust as what the nursing facilities have to report out quarterly. So, I guess I would have to talk about, again, how are we categorizing private residences and measuring the quality of that versus an institutional level of care. So I think those are some considerations that I think would warrant more discussion as far as reporting out on specific individual homes. We certainly have spoken with a lot of people about provider agencies in general as far as what their performance measures are when Doreen's team goes in and does their inspection. So if we see, or if her team sees a trend in either fire safety issues or people eloping or just overall staff training, her team does that plan of correction and they report back out to her. But I think it gets a bit difficult when it's an individual's home and looking at those strict measures like we do in the nursing facilities.
And just as a quick follow-up, I totally get that. I mean, what I'm concerned about with the measures in the nursing homes, they lead to practices that may not be good just so that you can meet a number. So I get that. I'm just curious if that's where you were going with what you said.
When I was speaking earlier about needing more resources and money, it was more for like a complaint process. But to your point, I think if we were able to collectively, collectively, determine what quality measures the state of New Hampshire would want to measure, we could likely figure out how to put that into some shared system as well, and report back on an aggregate level and not a location level. So it would be different, like from adverse events in hospitals and AS. I mean, we wouldn't do it by location, but maybe, I think maybe having the discussion, but I was talking complaints.
I could follow up one more time. Yeah. So you really said something important there. We're aware that there's another commission created through Senate Bill 670, and I'm just curious if that would be a good job for them to consider, because you're bringing in the entire group of people that deal with these issues to solve that problem. Would that make sense?
Yes, that makes sense.
Representative Drago.
Thank you, Madam Chair. Earlier, you had referred to individuals, and I don't remember the exact terminology, but I think it was something along the lines of people with sexual behavior issues. Was that the right terminology you used?
I think I said problematic sexual behaviors.
Okay.
Yeah.
I think I know what that means, but can you just describe that?
Well, again, it's kind of on a continuum, right? So it could be somebody who has sexual innuendos toward people. It could be people who might expose themselves to other people. It could be individuals that have had a sexual aggression toward people. So any of those adverse sexual behaviors would fall into that category.
I would imagine a lot of those cases have just been shown in the homes and et cetera like that. And most of them probably didn't stand trial. I would guess that they don't have to register as sex offenders for doing that.
Correct. Yeah, we have a process in BDS where under RSA 171B, where if anyone is not particularly related to sexual behaviors but criminal activity, if they were a registered sex offender through the regular registered process, they would show up on the registry. But if not, then they just might have had incidences that are not not rising to a sex offender level, but have behaviors that may be inappropriate, but not at a felonious level.
I don't know all those laws, but I would assume exposing yourself to other people, the general public would probably have to register as a sex offender for doing that. If this happens in one of these houses, are they having to register?
Well, they would go through the same due process. So I don't know if they would necessarily register. I don't know the avenue of how that works, but they certainly, if they were to go and offend somebody in the community, they certainly can and have been charged with whatever that offense was. And depending on their cognitive ability and, fit to stand trial, they would go through that same regular process.
That was actually more of a comment now, is I just want to make sure that the general public, if my neighbor, you can look it up right now. If you want to buy a house, you can look up and see
Of course.
if somebody, if you have kids, that's probably one of the first things you're going to do. I'm thinking to the house in Raymond, someone can move in, the neighbors all have kids playing outside, and they may not know that this is a situation. So again, citing individuals on specific cases, it seems this could be a kind of a concern to a lot of the people in my town, and I would imagine if you asked other towns, they'd probably feel the same way.
Yeah, again, I think a good question for an attorney in the Department of Justice, as far as, what's public information, as you said, I think everyone knows how to check a sex offender registry, but that goes through a judicial process in order to get somebody on that. These individuals, if they were on the sex offender, if they were convicted of that and on the registry, that would be public information. So I think they would have to go through that same process, but I understand what you're saying. But there are people other than people with developmental disabilities who have unsavory behavior that, are not on a registry or that may be your neighbor too. So I just want to make sure that we're not automatically thinking that, the majority of our people that we're serving in these environments have, inappropriate sexual behavior. It's a very small subset of the people that we serve, but completely understand your concern.
No, and I agree. I don't think it's just, I don't think it's the majority by any means, but I also think we as a state and you as a department, we have the responsibility to not only protect these individuals, but we also have a responsibility to protect everybody around that live around them, because they are, at the end of the day, these homes are a function of the state. So it's your responsibility as well to make sure that the neighbors are protected.
Yes, and so if there was any, due process as it relates to somebody being on the sex offender registry, then that would be highlighted in the sex offender registry, and they would show up on the registry.
I also wonder, I mean, we all agree that there are many instances, far more instances, where the system is thriving, working. Individuals are thriving and working, and we have these instances that have been brought to your attention, brought to our attention, that are not acceptable. So I wonder, as you're exploring what needs to happen next as a study committee, that we take the whole population into consideration, and if there are going to be any changes, maybe those changes be limited to the smaller population. I don't know, I'm just like throwing that out there, but I would hate, and I think we all agree, to see some significant changes happen that would cause more harm to the majority of individuals, both within the system and neighbors, than the really, I don't have the words to describe what we all know has occurred in the last several months.
Any other questions from the committee? Seeing none, I'd like to thank you both for your time and for the packet. Could you send that to our committee electronically?
Yes,
Um,
absolutely.
And actually, in the interest of pages, can you do it more as a written form rather than with all?
Oh, sure.
You see what I'm
Yes.
saying?
Yep,
Yes.
absolutely.
Thank you so much.
Of course. Thank you for having us.
Thank you.
Thank you.
I'd like to call, invite Sandy Pelletier from Gateway Community Services to come before the committee.
Here? Okay, there we go. Well, I started with good morning, but we're close to the afternoon, so thank you so much for this opportunity. I'm here at the invitation of Chairperson Representative Barbour. My name is Sandy Pelletier. I am the current CEO of Gateways Community Services, one of the large nonprofits in our state that serve individuals with developmental disabilities, individuals with acquired brain injury, children and adults with autism, elders, and also veterans. We currently serve about 3,000 individuals across the state of New Hampshire, and we are at this point, I think we are one of the 10 designated area agencies, and I believe our census were the larger area agency in the state. I'm here to talk more about housing, and I want to just share a little bit about Gateways and our housing efforts. Currently, we support, with partnership with our provider agencies, over 313 people residentially. That is individuals that live in either group homes or shared living facilities. And we also serve 20 of those individuals are what you've been discussing considerably today, which is individuals who are defined as needing intensive treatment services or what we call step-down programs. Housing has been a critical component of our organization for many years. Gateways is a 501c3, but we also have a C2 corporation that was established by the board 30 years ago, and we currently oversee 13 properties. Of those properties, 12 of the 12, one is a office building, but the other 12 currently eight run as group homes and 4 run as enhanced family care. Usually we sublease those to other nonprofit providers that act as our collaborator. I want to be very candid. I've been doing this for a number of years, probably more than I want to admit at this point, but in my history, we have encountered community challenges. Early in my career, we had challenges with the town of Merrimack, the town of Hollis, and the city of Nashua. And we learned some pretty, I would say, important lessons at that time, and it's something that has really guided Gateways. One of the reasons I believe I'm invited is because last fall, there were a number of concerns being raised in our communities, and one was the town of Hollis. My current board member is former Senator Peggy Gilmore, and she's Gateway's board president. And she made an introduction to me with Representative Barbour. So Representative Barbour and I've been a little bit on cell phone speed dial here over the last number of months. I use those opportunities to do a little bit of community education. Basically, I don't want to minimize what's happening because it's very concerning. As a system, we've worked very hard. In the beginning, there was a lot of concern when people were coming out of the institution, when there was the development of community residents. There was a lot of misinformation happening throughout our state. And I think as a system, we've worked really hard. The point of all of this is that the individuals we serve and the families we work alongside, their sons and daughters deserve to live in our communities. And we have seen incredible success, incredible opportunities, and I've witnessed many of that over my career. And New Hampshire is I'm proud of New Hampshire. We've had incredible collaboration with our community, with our leadership, with policymakers. And because of that level of collaboration, I think New Hampshire has a pretty strong system of support for individuals with developmental disabilities, and one that needs to continue. So I'm hoping that some of these events over the last number of months are not events that drive the system in what I want to say in a more challenging way. I think we need to recognize it and witness it, but I want to acknowledge that there's been a lot of community collaboration, and that helps. So let me just give you a couple of recent examples, and I think I won't go into the weeds and the detail that my counterparts did in the department unless you have specific questions for me regarding those. But we also, as an organization, shortly after the pandemic, there was American Rescue money made available. And I know that some of these providers that currently, that Doreen and Melissa referenced, applied for a considerable amount of funds to bring individuals back to New Hampshire. Gateways was one of those organizations. We also applied for some of this ARPA funding to create a new home residence for individuals who have more challenging behavioral needs. This is how we went about it. It was already a home in Milford, New Hampshire. My CFO and I went to the town administrator. We met with them. We explained the program at hand. We gave them detailed information. From that point in time, I also had some conversations with Governor and Council Member David Wheeler, invited David to the property, Governor and Council Member David Wheeler to the property. He visited the property with me, had questions and concerns, raised them. I addressed them as best I could. That kind of effort, it took a couple of years. The home opened maybe a year and a half ago. It serves 4 individuals, and it has been a relatively positive success in our community. Recently, Commissioner Lori Weaver asked me to introduce Governor Ayotte to our efforts and our process. So this past June, Governor Ayotte and the commissioner and some of her leadership team, Melissa Hardy was there as well, and Jess Gordon, and to talk about how we went about doing this in our community. Also present at that meeting was the Milford administrators. And they were there, and they talked about their long-term collaboration with Gateways and the Provider Organization Summit, and how along the years we've continued to use our efforts to educate the community. We work with the police department, the fire department, and we do that on a regular basis. And that was an example of just how we go about it organizationally. There isn't a policy or procedure. It's not like the department says you've got to do this, but it's something that we learned as an organization many years ago, and it has really worked to our advantage in our communities. So I guess, again, I gave examples of this. We currently are involved with the town of Wilton. We're working on some community development block grant. My staff have met with their administrators. We own a home there. We've had a longstanding home, a longstanding relationship with the town of Wilton is another example. They even wrote a little article in the Monadnock Ledger about our long-term relationship. And I just use those as examples on how we have built on what we believe were our successes in the past by really engaging with the community. our staff, we have clinical service coordinators. They work alongside the individual who are identified. They look at their clinical needs. They get the appropriate evaluations and assessments. They make sure that the provider organization is well trained. Referencing back to that Milford home, one of the things that we did do with the ARPA funds, not only did we repurpose the physical environment of that home, but we also used significant amount of money to retrain the staff and to really work to make sure that they met a clinical standard necessary so that they could mitigate any challenging behaviors that the individuals might present with. And that really also worked positively to our advantage. So those, I just here to share some examples with you. When the issue in Hollis occurred, I shared with Representative Barbour that was not a Gateway's home. We were not, and it wasn't a Gateway's client. So I was not familiar with the situation. I did at times have been called about certain situations, and I take a few steps back and I really ask the provider agencies to re-engage with their community when that happens. And we're in the southern part of the state. There have been numerous homes opened in our region. I think partly because of the demographics, the opportunity for workforce is probably more relevant there than maybe in the northern part of the state. So there are a lot more homes in our region than maybe there were 3 or 4 years ago. But we've worked very hard to educate our community and work with our community partners.
Thank you. I have a question. With regards to the Milford home residents, you said there are 4 residents in that. And it sounds like Gateways really makes it a point to have that community engagement. Is that a requirement for providers?
I think it's. I'm not going to sit here and say there's a policy that says you need to do this, but I think we all know it's best practice, and I think those of us that work in this field, particularly here in New Hampshire, what I've always worked in New Hampshire, so I really don't know what it is in other states, but I think we realize that our efforts are very much community centric.
And I appreciate that. And I'm curious from your perspective, as we are here to try to, mitigate these issues, possibly through rules, legislation, et cetera. Do you see your best practices, which clearly makes a difference within the communities, engaging with town officials, working together? Do you see that as something that should be required when these homes are brought into towns?
I don't know that requires legislation, to be honest with you, or rulemaking. I think it requires better efforts around education with our new providers coming into the state.
Yeah. Go ahead.
Thank you, Madam Chair. Thanks for taking my question. My child gets his care through Lakes Region Community Service. I'm very thankful for all you guys do. I'm just curious about oversight and hierarchy. We've heard 2 different things. We've heard from the folks from HHS, and now we're hearing from you guys. Is it when there's issues, who's the first one that's aware of them? Is that you, or is it HHS, or where do people go? Because I'm just seeing there's a potential problem of confusion as to who's kind of providing oversight.
At Gateways, we're primarily the area agency plus the service coordination agency, and we also do quality oversight. So if there is an incident of one that involves one of our individuals, we're the first to know.
I'm just curious too, because these 2, I'm sorry, the facilities we heard about last meeting, were they under any one of the area agencies, or are they like totally independent?
They're not. When you say under the area agency, the individual that is being served is supported by the area agency. We do not have authority over the provider.
I gotcha. So that would be HHS.
Yes.
Gotcha. Thank you. I understand much better.
Do we have any other questions? Seeing none, thank you so much for your testimony, and I appreciate that you will be emailing this to us.
Thank you.
I'd like to invite Rob Gillis, representing the New Hampshire Private Providers. I hope I got that right.
Still good, still good morning, I guess. My name is Robert Gillis. My wife Noelle and I live in Hancock, New Hampshire, and I'm the executive director for Monadnock WorkSource. We're a small provider agency in the Monadnock region. Excuse me. That's been providing community-based services for 55 years. I've been with Monadnock WorkSource for 17 years, and when I first was hired by Monadnock WorkSource in 2009, my job was to oversee the various residential models that Monadnock WorkSource provides. So some folks that live in their families' homes, some folks that live independently in their own apartments, and enhanced family care shared living homes. Monadnock WorkSource does not have any staffed residences or what folks think of when they think of group homes. We did years ago, but honestly, it's hard for those to turn a profit or even break even. And so our agency chose many years ago to not offer that staffed residence model. In my current role as executive director, we're a very small organization. I have myself as executive director. I have an administrative assistant, 3 program managers who oversee 18 staff, and we support 28 individuals in a variety of disability services throughout the Monadnock region. We provide job support through our supported employment program. We provide community participation services with a home base in Peterborough, where people come meet up with their staff, see their peers, and then go out to community activities throughout the day. And then we have 10 enhanced family care homes spread throughout the greater Monadnock region that each of those program managers have a caseload that they oversee those shared living homes. I didn't put together a presentation. I'm more here if there's questions about many of the topics. I've been doing this a long time. I also sit on the Quality Council's Rules Committee and review rules as they come up for consideration or renewal. And I've been participating in that group for about 2 years now. Again, I think the enhanced family care shared home model is truly the epitome of community-based living as federal Medicaid would like to see. And I feel it is a model that should be overseen, but also should be preserved because it truly is community-based living at its best.
Thank you. I have a question for you. So with regards to the activities that you provide or other providers do in the state, is that how do the individuals who are living in the enhanced home situation, is that a requirement for them to take part in these, or how does that work to get these, to help them get out of the home, to be more socialized?
Certainly. There is an expectation for individuals who are in any of the community-based services to be out in the community. each of our individuals has an individual service agreement that the team, with the input from the individual and a guardian, if there's a guardian involved, helps to create goals that that individual wants to work on for the agreement year, that are based primarily on, helping them to develop skills to become even more independent so that they can live with the greatest amount of independence residentially, but also so that they can become contributing and valued members of their local community. So that team of people, driven by the individual and their guardian, defines what they would like to work on. Agencies like Monadnock WorkSource then takes those overarching goals and converts that into daily activities in the community that we feel and the team feels, will help them achieve those goals. It is a voluntary program, so if they're supposed to be going out to work that day, we don't and can't force them to go out to work that day. They have natural consequences if they decide not to show up at work, like we all do. But we have a calendar of weekly events broken out into daily blocks of those activities that the team has agreed upon for that individual to participate in. Both residentially, they have goals of how in community living, the goals that they would like to work on, as well as in our day program and in our vocational program.
Representative Nagel.
Madam Chair. I want to make sure I understand. Who are you representing again?
I represent Monadnock WorkSource, is the agency that I'm executive director of. I'm also a member, Monadnock WorkSource is a member of the New Hampshire Private Provider Network.
All right.
And I was asked to fill in for one of our members on short notice to be here today. So I represent one of the members of the Private Provider Network, but I do not speak in an official capacity as a set representative of the administration of that group.
I have to tell you, if I can, my dream is integrative care, and the level of collaboration you have. I'm looking at your website, but it's great. It's nice
Thank
to
you.
know that exists in New Hampshire. Thank you.
We work really hard to be contributing members of our local community as a local business, but also our clients do better when we involve our local community and have stakeholders, because our folks are employed by local businesses. They have coffee in local coffee shops. They bank in our local banks. And so we try to bring all of those entities together for the benefit of the individuals we support.
Thank you.
Do we have any other questions from the committee? Seeing none, thank you very much, Mr. Gillis, for your testimony. We appreciate you coming today.
Certainly.
I'd like to invite Marissa Berg from the Community Support Network. We're all set. Thank you so much. I'd like to invite Matt Cordero from One Sky Services.
I think we have surpassed morning, so I'll say good afternoon, Madam Chairwoman and committee members. I actually am here representing Farmsteads of New England as the interim CEO. We are a residential provider. And I had taken the liberty to send you some written testimony beforehand. It's about 4 pages. I'm going to save us all the time and energy and effort of reading that verbatim and just touch upon some high area points that I think are important for us to kind of look at, being solution focused. BDS has staffing vacant positions, same with license and certification. We need those positions filled. If we fill those positions, much of what you're looking at as being issues can be resolved through the new regs that we have put into place. licensing certification, which, just for a little edification, I've worked up and down the East Coast, Florida, working with intensive behavioral health needs, Maine, Massachusetts, Vermont. I can probably list a few more states if you'd like, but I've had the opportunity to work in different states with different DHHS systems and administrators. I don't say this for brownie points or anything, and I've been told I'm not allowed to use names anyways by our lobbyist, but we have the best people. They are extremely collaborative. They work well with us. And I think a lot of the issues and options or problems that we are seeing that you folks had to deal with, particularly in the town of Raymond, because that is my catchment area, are due to one really bad provider running into the state. And I took the liberty to look it up. They weren't listed on the OIG exclusion account. So that's probably why they were able to enter into New Hampshire, even after there being the fraud recovery in New York, I think is what you folks were referencing. But just to get back onto track, one of the biggest issues that I see from working in other states, we do not have all of our rules and regulations in one booklet based on service. So if you come in as a new residential provider to the state of New Hampshire, there are a litany of rules and regulations that are not in one place. And if you don't hire the right consultant or you don't know what you're doing, you're going to immediately run afoul of those. So I think having them all coordinated and put into one place for a new provider to be able to look at, see, understand, trainings for our staff, what our expectations are as a state would really help. In the 7 years I've been in this state working as an area agency CEO, this is my other hat. I have seen new providers come into the state, immediately run afoul of the state step in to provide to support them and help them. And I've watched organizations thrive because they took a collaborative and a cooperative approach. And then I've watched other ones lose their licensure certifications and be run out of the state because they decided they weren't going to take a collaborative approach. Community options is just the latest version of that. The other organization that was struggling in the same town, from my understanding, has found their footing. They are working collaboratively with people. And I don't know from the state's perspective because I haven't talked to them about that, but from outside voices, and they are doing a much better job. So when we talk about, what our best practices are, one of them is to work with our counterparts at the state. When you look at what this committee is trying to accomplish, other states have done this. They've had these conversations. They've looked at what works, what doesn't work. You have California, Oregon, Washington, West Virginia, Colorado, Connecticut. All of them, with exclusion to California, set density, setbacks, things that prevent people from being able to live in their own communities. I ask that, even though I give them to as examples of places that have done this work to make it easier for you to see what other places have done, that we look at the best practices that are uniform across most of them, if all of them, and we exclude the things that prevent people from living in their communities. California is a great framework. They take a lot of time to make sure that being able to live in a community makes sense for the community because we have to follow the zoning and the laws of the setbacks and all that for a single family unit. You can't treat a home for people with disabilities any differently than you can treat a home for myself or for yourselves. And so it allows people to actually live in the community the way the community is actually developed to be lived in. But it makes it incredibly clear and very painful for NIMBY kind of tactics to prevent people from living in their communities or kind of situations that, one of my organizations is dealing with right now with the town of Raymond, where we have a select board that has been a little hostile towards us, even though we haven't had calls for service or anything like that. And that's very different from the relationship and cooperation and collaboration that I've had with Representative Drago. And so we want to make sure that that stuff doesn't permeate through the rest of our state. There are statutes, and there are also legal precedents. And I sent that committee a letter of opinion that I received for House Bill 731 a couple of years ago, that actually talks about how these homes, you can't change the ability to site these homes wherever the home needs to be sited, because basically everyone has the right to live wherever they want to live. It's a fundamental right. It also talks about not keeping people from overtaxing those properties. But we do have to live within the community as good members. At Farmsteads, we have phenomenal relationships with the town of Hillsborough, with the town of Epping. We actually have planned unit developments where we have the town of Hillsborough. We have 28 single bedroom apartments located in 6 buildings. Technically, 2 apartments are also in a 7th building. We have 32 units being currently built in Epping. That project alone, we're injecting $16 million worth of funding into that community using local contractors. We're creating a lot of jobs. Each site brings in about $5 to $6 million worth of cost of services, which go into well-paying jobs for people who live locally. And then we are purchasing to repair and fix things on a constant basis, or maybe a tractor, or what other farm equipment we need. It's not always farm equipment. Sometimes it's a lot of other different things. And so, we provide an economic benefit. So when we're looking at where these homes are sited, we also need to think of the economics of the towns that we're in. When you look at communications with the town, I think we should have to have, as a best practice and part of our regulations, a requirement that we communicate with the town. I have never seen a circumstance where you haven't had to communicate with the fire department or with the police department. When we entered into the town of Raymond, we let them know that we had purchased a home. We were going to take that from a 3-bedroom to a 4-bedroom. It was going to be specifically for people who are non-ambulatory in the last phases of their lives. It's a place for them to come and live, and also to pass in dignity, so that they're not in an institutional setting. We had a really good relationship in the very beginning, and that worked out really well. And then there were some changes on the select board, and unfortunately, it's that relationship has degraded. When we look at maintaining a neighborhood character and being a good neighbor, these things can be captured in our rules and regulations that we have through amendments. And one of the things that we can do is give the licensing and certification team the ability to be able to look at, are we maintaining the properties? Are we making sure that the properties are in the character of the neighborhood? Are we creating problems? There is no central place to just go and make it easy to be able to call them and say, I have a problem. There's also no ability to hold someone who makes false reports accountable. And that's important, because we do have, and we run into neighbors that don't want us there. And sometimes it's just they don't understand what we do. And other times, we have staff members that are not great, and we have to hold them accountable. Licensing and certification, giving them the teeth and the ability to hold us as administrators accountable, will probably force some people that don't want to pass that accountability down to have to pass that accountability down. Hold on one second. I was writing this quickly. The other thing too, the nuisance complaints, that's a training issue. So if we updated our training requirements for the state and made that a requirement, what is a good neighbor? Not flying down the road, not screaming, not yelling, not leaving trash out, working together. We made that a training requirement. Licensing certification will determine whether or not we are doing that training. And if we haven't had that person trained, that's going to be an area for them to hold us accountable. That's also an area for us to start implementing some best practices. Our trade association with the area agency, CISNY, offers a lot of different trainings. It's an opportunity to be able to partner with an organization like that, or with the PPN, to develop these trainings and then make them uniform across. I mean, I can go on and on. I just, I want to make sure I'm utilizing your time in an effective manner. So, is there any questions I can answer for you?
Representative Nagel.
Thank you, Madam Chair. Thanks for taking my question as always. You had specified that you thought that the regulations need to be in one place, and I totally understand that because trying to weed through our statute is always a enjoyable process. Do you have a recommendation as to who should be doing that? Should that be a statute? Should that be an HHS thing to do?
Well, I think the problem is that we have a lack. I apologize. I'll try to speak into the mic a little bit better. I don't have a singing voice, so I don't do this. I think we need to backfill the positions that are vacant if we're going to ask that of DHHS. I think if you wanted to have CISNY or PPN or a combination of the two, I think you could probably do that for a nominal fee. It's getting everything together into just one packet that's service-based. And the state of Florida Agency for Healthcare Administration, known as ACA, if you go to their website and you type in provider manuals, you literally can go right to the provider manuals and like apply behavioral analysis. It tells you what all the staff requirements are, the documentation requirements. It's literally a book to how you run a behavioral analysis business. If you want residential and licensing, again, it's literally a book to how you run that. So a new provider coming in would say, okay, here's who I need to talk to. These are the bureau chiefs. These are the area agencies. It would have to be something that would give them a very clear understanding and description of not only how our system works, but how they're going to be held accountable and what their expectations are. Our biggest issues are not our homegrown New Hampshire providers. Our biggest issues are people coming in from out of state, and like the idea that we're an agent of the state and the town has no authority over us is an insane proposition to me. That could only come from someone coming from out of state. But the town has dominion and authority over us. If we want to put up a fence, the town has the ability to say no. But it's within that parameters of the fencing rules and regulations. To the point of these people are not capable of leaving on their own, that might be true for some people, but the overwhelming vast majority of individuals live their lives the way you and I live our lives because they're no different. And so they might need someone to drive them. They may need someone to help recognize unsafe situations, but it's not something that I would say is like, I wouldn't call it a facility. And I've worked across like multiple settings. I've worked in juvenile justice. I've worked in high intensity behavioral. I've worked case management. There's a lot of different things that I've had contact with. Facilities is a very specific term. But, you know, these community residences, I can understand why you would look at it that way. Because the schedules that are put out, and like as a great example, what happens when someone gets into a car accident? What do you do with that documentation? So for farmsteads, they either carry a binder that has all the medical information, or on your phone, you can pull up the EHR, the electronic health record, and you can say, this is Matt Cordero, he's got high blood pressure, devastatingly handsome, here's all the issues that we're going to address. He's a little delusional. These are the things that we talk about. I don't have high blood pressure, the rest is true though. So it's one of those things where it's the provider's policies and best practices. The state of New Hampshire doesn't have an accreditation process. That might be something that we should look at, but the cost of that's going to go up. And we already have tight budgets as providers and as nonprofits. The majority of us are nonprofits. So we have to look at, is that something that the state's going to sponsor? Are we going to look at rate increases at a later date? Do we make, funding contingent upon us becoming accredited? There's a lot of different ways that you can kind of skin the cat. Do we need legislation? I don't think we need legislation. I think we need certification changes and updates. We may need legislation to back up those changes and updates. But I think you have a willing group of people to work with you. And I find legislation is usually the hammer that you need to take out when you don't have people willing to work with you. But again, I'm not a legislator, so I'm just kind of guessing at this one. And then, let me see. And as far as identifying where homes are, you wouldn't want anyone to identify where you live. I don't want anyone to identify where I live, even though it's public information. But if we're doing it based off of their behaviors, that's a red flag for me. To your point, do we need to make sure we protect the populace? We absolutely do. But that gets back into making sure that we have strong regulations and rules that we can set up with providers that do this as a expertise and have done so for the last 40 years in New Hampshire, and work with you folks to be able to make those recommendations so that GELCAR, DHHS, the provider network, the area agencies, everyone can come to a consensus as to what makes sense. The last thing I'm going to say is this bill started out as something totally different. And then you guys pulled a complete U-turn on this and you said, all right, let's get everyone around the table. I haven't seen that ever across any state I've ever worked in my entire career. Not that I'm old, I'm not. But it's one of those things. Devin's still very handsome. But it's one of those things where it's greatly appreciated. And all the kidding aside, having people being able to come and communicate with you directly, being as open as you all have been and are, is something that I greatly appreciate, and I hope continues through not just through your leadership, but I hope your example extends out, because we have a saying, nothing about us without us, and you guys are living that for us, and I appreciate that. So thank you.
I appreciate a lot of what you said because my neighbors have tolerated a Buffalo Bills and Buffalo Sabres fan living in their midst for the last 31 years. I'm not as good looking as you are, but at the same point, is there one state that, or a state that you, or states that you can give us a list that have done a great job of putting that framework together of all the regulations that we should look to?
Yeah, I would say California did a really good job as a framework. I would also look at Florida for some of the stuff that they've done, because they actually have kind of looked at like what is a health, like they bifurcated what is like a basic community residence, what is a community residence that's there to support people with problematic behaviors, not just sexual problematic behaviors, but just in general. And then they also have community residences that are focused on healthcare solely. And so it allows people to be able to have a specialty. That specialty is paid at a certain rate. And those things are a little bit easier. It also makes it easier for their licensing and certification paramours or counterparts to our state to be able to work within those frameworks. But again, everything always comes down to money. Do we have enough of it? Do we have enough to go around? If nothing comes out of this other than, we get the positions that are vacant in both departments filled, that is, to me, like the most that needs to, that's the focus that needs to be addressed.
Any further questions? Seeing none, thank you so much for your testimony today.
No, thank you all very much.
So we've heard from those agencies who were able to join us today based off the invitation that we sent. Now we'd like to open up the floor for public input. Is there anybody else that would like to speak to the committee?
Thank you, Chairperson Barber. Thank you, committee, for allowing me to speak today. My name is Will Walker. I live in Hollis with my wife and 27-year-old son with autism. I'm also a legislative liaison for Gateways Community Services, advocating for people with developmental disabilities. I'm on the select board in Hollis, but today I am representing myself as a parent and a neighbor of people in the Hollis area. The incidents that happened are indeed very horrible. Okay, I attended the Denise Ricciardi meeting between Bedford, Hollis, and I think another town to hear what families had to say. I've talked with neighbors in the neighborhood where it happened in our town. And they are very, very bad. They're bad for the neighbors. They were bad for the people that were being served. There's no doubt to that as well. I am concerned about the risk of this committee overgeneralizing the people and the problem. Okay, so I just want to just take care. I want to just talk about my son, who is a person in this category, in this population. Okay, so he knows right from wrong. He knows what he can and cannot do. I heard questioning from Senator Murphy about it almost implied people were in prison, right? They didn't have the choice of whether they could leave the house or not. My son knows what he can and cannot do. He chooses not to leave the house because he knows he needs help navigating society. That does not mean he's not being integrated. Okay, so just because he chooses not to go out without help does not mean he's not being integrated in the community. He participates in Meals on Wheels. He adds value to society by bringing people food. He goes to the dump. We have fun at the dump, and people recognize him in the community. So integration doesn't mean independently going out. Integration means being able to go out into society in a least restrictive environment. Okay, so I just want to make sure that that's clear. So with all this, and I'll just give you a quick story about Meals on Wheels. Okay, so Meals on Wheels, he has help. He has somebody drive him. He has an aide that takes him out to deliver meals to people's homes. And I just to give you the benefit, obviously he's benefiting society by bringing food to people in the community. Okay, but it's also benefiting him. And I asked him if he liked Meals on Wheels one day, and he said yes. And he's a pretty nonverbal kid. And I asked him why, and this floored me because he gave me a full sentence response. And he said, "It's because I'm helping people." Okay, so we have this really two-way street of he's helping society, but society is also helping him. Okay, and that's what the value of integration is. And what I'm concerned about is that the decisions of this committee or the recommendations this committee make are going to impact the day that comes when my wife and I can no longer provide care for my son. Okay, there's going to be that day where we can't be the primary care providers for our son. And will he be viewed as a member of society or will he be viewed as an outcast? Okay, so I want to be very careful about that. At the same time, will he be safe? Okay, so we are concerned about the safety of our son and the regulations and the administrative rules around what's going to ultimately happen to him as he becomes somebody depending upon housing for somewhere else. Okay, so please take care in your recommendations that you make. I want you to consider that you address the specific problems that came up and not treat these population as an entire whole. Okay, and I'm sure you are thinking about that. Okay, and you guys have brought people and allowed people to speak to hear it, and you've heard this before. So, and I agree with Mr. Cordaro that this may be about updating the administrative rules and updating the regulations around this, but also that has to come with appropriately funding the things appropriately so that the department can do what they need to do. Okay. So I want to thank you. I didn't really prepare anything. This was chicken scratch that I wrote down, but I do care about my son. I love my son. I care about his future, and some of what happens to him is in your hands.
Yes, Senator.
Thank you, Madam Chair. I want to be very clear. Last time we met, we heard several stories about instances where residents that were essentially locked into a home could not leave. Different than we've heard today. For want of a better word, escaped and got away from the people who were caring for them, and in one case went into someone's home and was discovered by a resident in her living room. And this person had a demonstrated, documented history of violent behavior. And the people in the committee haven't discussed it amongst yourselves yet. We're still gathering information. But speaking only for myself, I think we're going to look at this, or I'm going to look at this as something to deal with sort of with a scalpel and not a club. And people like your son, as you describe him, would certainly never be affected by anything I would recommend. I appreciate the hard work that the people that have spoke to us today are doing, and I fully support integrating people into the communities as best as possible. And people like your son should never need to worry about where they're going to live. We're talking about maybe doing something about situations like the ones we heard about last time we met, and only in those circumstances with people maybe that have a history of violent or sexually inappropriate behaviors. Your son sounds like a wonderful person, and I would never worry about it. Never want you to worry about where he would live.
Well, thank you. Now, was there a question there? Aren't you supposed to ask me a question? Or
Would you believe?
would what I
That's
believe?
the
Yes,
trick,
thank
right?
you. So I thank you very much. And that was my concern, right, is that we view people as one population that's all behaving this way. And thank you for recognizing that people are unique and there's individual situations. And we all strive for a least restrictive environment for the people to give them the freedom that will make them safe.
Representative Nagel.
Thank you, Madam Chair. I kind of feel obligated to say this because I'm just a little curious, but like, you know, I'm in medicine for 42 years. I know I don't look it, but I have been. I'm sorry. I felt after what you said earlier, I feel obligated to say that, but Mr. Cadero. So, you know, we look at evidence-based, you know, decisions, and I actually wrote a book that has that in there. And we generally view as case reports as the worst level of evidence imaginable. Well, it's really not true. You know, we learn a lot from individual cases, and that's kind of like what we're talking about here, but it's dangerous to make broad sweeping policies based on a case report. At the same point, those case reports can allow you to tweak things. I do totally appreciate your concerns and fears because we've seen hyperbole create really bad public policy. So I think I'm very thankful that you brought that up. But I still think that what we're doing here is really important with that caution that you raised. And I very much appreciate that.
What I believe, yes.
I sorry, this is a soapbox.
No, thank you. Yeah, and you know, I would go as far to say is that these situations that happened, if we were taught to talk about NIMBY, okay, and this is based upon the public testimony that people had given, the neighbors and the people involved, I would go as far to say is that for these specific situations that were outlined, I could be accused of being a NIMBY, okay? I wouldn't want that to happen. I wouldn't want that to happen as a neighbor, and I wouldn't want to see it happen to people that were being served.
Any other questions? Seeing none, thank you very much, Mr. Walker, for coming.
Thank you.
Do we have anybody else that would like to address the committee? All right, well, thank you all for coming today. We're going to go and have a committee discussion, and thank you. Do we have thank you. Do we have any comments from the committee going forward?
Yeah, this is a very interesting discussion. It just, you know, most of my legislative career right now has been about 35 years, and what we've always tried to do is look at rules and regulations first, statute last. And I really enjoy the discussion we've had today. We've heard, you know, the recommendation that we start to think small, I guess, and maybe go big. And I think that was a really interesting observation. Statute is a big deal when you create that, because once that's in there, it's there. Rules are so easy to change if you get it wrong. And I really appreciate a lot of that commentary today.
Madam Chair, have we done or asked House or Senate research to do any research on how other states are handling this question?
Yes, we have sent several questions on and still working on bringing that all together and expecting that report by our next meeting. Prior to that, yes. I also wanted to schedule our next meeting.
It's a quickie. We heard Justice Department mentioned several times today. Is it on our list of people to have the folks from there testify before us?
Thank you for that. Yes, I have going forward for future, our next meeting, what I'd like to do is be in touch with the Fire Chiefs Association. We'd like to bring in a professional in the zoning and planning. And also now, after today's discussion, someone from the Department of Justice, I think would be appropriate. And also, I will be sending out a general invitation to anyone else that attended the meeting that was mentioned with Senator Ricciardi. So I will do that as well. And let me see. Yeah, the State Emergency Medical Services, the Fire Marshal's Department, the Zoning and State Municipal Association. And then CISNY was also planning to attend. So we'll have that.
Do you want me to invite the fire guy that I talked to about
Laconia.
earlier? Do you want me to do that, or just should the fire other person you mentioned suffice?
I don't think it would hurt to have both.
Okay.
Yeah. Is there anybody else that we should be inviting to that? So my thought is that we would have that meeting for testimony, and then if we think we need an additional meeting, our report is due on or before November 1st. So we should have a time together to discuss what will be in that report, unless you think that should I schedule 3 meetings at this point or just 2 going forward? I'm sorry, I keep looking over at you, Senator. I know, I am right-handed.
You're a normal.
Madam Chair, I would suggest perhaps one more meeting to gain information, and then perhaps a second meeting to discuss recommendations, and then we would need a third meeting in order. And that would be to schedule that now, but we would need a third meeting to ratify the report and
Thank you.
Approve it.
Okay, thank you. So with that in mind, I was thinking September 23rd. That's a Wednesday for our next meeting. And if you could check your calendars for October 7th, we can get those 2 on the calendar. 7th is also a Wednesday.
Works for me.
Okay. What's that? Wait, so we'll have those 2 scheduled, and we'll get the agenda together. I will get those invitations out. Is there anything else that we'd like to discuss today? No? Thank you for the incredible testimony and efficiency for today. So, and certainly we welcome further testimony if anybody should see that something's left out, and always welcome an email or a phone call if you feel the need for that. So that being said, I'd like to adjourn the meeting and thank everybody for attending.